there will be two parts. The first part will be anatomy and some congenital disorders. The second part will be more of the orbit. You'll see the lacrimal and eyelid parts tomorrow, okay? Let's just give a quick overview of anatomy. The important things, structures to look for: the globe to optic foramen, the optic nerve length of SLAC, 7 to 12 millimeters. You typically have some redundancy there. The dimensions, you don't really have to memorize, but it's just good to know the general dimensions. Width is usually longer than height, and know the optic nerve lengths, the intraocular, intraorbital, intracanalicular, and intracranial segments. So try to think about the osteology and break it up into the 7 parts, the 7 bones. Okay, and you'll be able to sort of organize it into your mind a little bit better. The goal in this bony anatomy is to think about how the bony anatomy actually relates to the non-bony anatomy. So starting off with the roof, it contains the lacrimal gland fossa, the trochlean supraorbital notch. It's adjacent to the anterior cranial fossa and frontal sinus. The lateral wall consists of the zygoma and greater wing of the sphenoid, and that's adjacent to the medial cranial, temporal, and temporalis fossa. The floor contains the infraorbital nerve and canal and forms the roof of the maxillary sinus. The bones are the maxilla, the palatine, and zygoma. In the thinnest area, this is a question they like to ask, is the posterior medial portion of the maxillary bone. The medial wall is the thinnest bone is the lamina papyracea, and that consists of the ethmoid, lacrimal, frontal process of the maxilla, and the lesser wing of the sphenoid. So again, let's talk about the optic canal. It's 8 to 10 millimeters long, and it's located in the lesser wing of the sphenoid. So this is typically enlarged in children with optic nerve gliomas. And it's important to know that the contents of the optic canal, the optic nerve, ophthalmic artery, and sympathetic nerves from the internal carotid plexus. It's also important to know the contents of the supraorbital fissure, inferior orbital fissure as well, and the nasolacrimal canal, which extends from the lacrimal sac fossa to the inferior meatus under the inferior turbinate in the nose, which a lot of you have seen in surgery, and that's another question that they like to ask, for example, in patients that have congenital obstruction of the valve of Hasner. And then the zygomaticofacial and zygomaticotemporal canals. Right. And it's good to familiarize yourself with the different sections in the anatomy. The annulus of Zinn is a fibrous tissue ring which arises from the paraorbita that surrounds the optic canal and straddles the superior orbital fissure. So the 4 recti muscles originate there. So in patients with optic neuritis, there may be pain with eye movements related to this anatomy. So through the annulus, there's the optic nerve, ophthalmic artery, sympathetic nerves, oculomotor nerve, nasociliary nerve, and abducens nerve. But more importantly, just try to remember what's outside the annulus, and everything else kind of falls inside of it. So outside the annulus is the trochlear nerve, frontal and lacrimal nerves, and the ophthalmic veins. So important question that I noticed that a lot of the residents in grand rounds talk about where the 3rd and the 4th nerve come out and how it changes on section. So when you see the internal carotid artery, just try to organize the anatomy in your head where the 3rd comes out superior to the 4th, and when it's not there, the 4th is above the 3rd. That's just something that you can memorize. The facial anatomy, I think the most important thing is know the major branches of the facial nerve: temporal, zygomatic, buccal, mandibular, and cervical. A lot of people like to make sort of these to Zanzibar by Motorcar, and everyone has something sort of different in their head. But whatever works for you, it's an easy way to remember it. There is a lot of facial anatomy, which I don't think the majority of it is not going to be on the boards. You can separate those into the mimetic muscles, the facial fascia, and the deep mimetic muscles. Congenital disorders usually revolve around the suture lines. Okay, so there's the metopic suture, the coronal suture, the anterior fontanelle, and the sagittal suture, and the lambdoid suture. Okay, so craniosynostosis is really as a result of premature closure of one or more cranial sutures. There's a lot of theories as to why certain formations occur, but those are all theories of etiology. You don't have to know those. So the types are important to know. The simple is 1 suture, complex is 2 or more sutures. In secondary, there's primary and secondary. Secondary is systemic disease, rickets, or hyperparathyroidism. They're not that common, but common enough to see on the boards, obviously. And typically, their increase in intracranial pressure can cause this deformation. So plagiocephaly is when there's a fused coronal suture on one side. Trigonocephaly is a fused metopic suture. And scaphocephaly, fused sagittal suture. So Virchow's law for craniosynostosis says that the growth of the skull stops in a direction perpendicular to the suture. And there's compensatory expansion in the suture contiguous to the permeable suture. So if there's a stenosed sphenoethmoidal suture here, the direction of growth would be this way. And if it was this way, then direction of growth would be parallel to that, contiguous to the permeable suture. Cleft palates, you probably won't see on the boards either, but it's good to know just because it organizes, again, the different craniosynostoses in your mind. There's a unilateral incomplete, which doesn't extend to the nasolalia. The unilateral complete does, and the bilateral complete. And they also have cleft palates. Okay, so there's many synostoses to know. Cruzon is a common one. Know that it's autosomal dominant, but there are about a third to one-half of patients with sporadic mutations. Okay, and they all involve the FGFR2 gene. Okay, so orbital findings, they have shallow orbits, which lead to proptosis. They do have V pattern exotropia with maxillary hypoplasia, and usually normal intelligence. So the board may give you a patient scenario with a patient that doesn't have some sort of mental incapacity, and so Cruzon may be on your differential. APERT is also autosomal dominant, and really I think the genetics are important questions to know for these patients. Okay, so they also have midface hypoplasia, short palpebral fissures, and they're descending, and they actually do have MR, okay? So now let's move to thinking about how to approach orbital questions and patients. Structure and function, sensory and motor changes, and history. In your mind, when you have a patient, the clinical disease, I think the four important things to think about are inflammatory, infiltrative, mass effect, and vascular, as Rootman described. So always think about the differential diagnosis. There's different presentations, and they can be inflammatory, which also involves infectious, neoplastic, structural, vascular, and deposits and degenerations. If you just think about those things, I think that can organize a differential very well for you. Another important thing is onset. So is it hours, is it weeks, or is it years? Okay, and all these things here that you see are important for history. And then there's the sixth piece. Pain can be inflammation, infection, hemorrhage, trauma, or malignancy. Globe displacement, again, that's a sort of mass effect, something that may cause proptosis, but something that isn't necessarily infiltrative. So axial proptosis is typically intraconal, non-axial is extraconal. Superior displacement, again, think about the anatomy as it relates to the bony orbit. Maxillary sinus tumor, inframedial, dermoid, or lacrimal gland. Frontal sinus. Bilateral, the most common, Graves' disease, but think about lymphoma and idiopathic orbital inflammation. And a lot of people call that pseudotumor, but we don't like to call that here. And enophthalmos, which is sclerosing tumors or fractures. Progression, an acute progression, you can think about inflammation, infection. I'd say hours, even more acute, would be hemorrhage. Months to years, tumors and Graves. Palpation is super important. We had a patient once that, just on palpation, you can tell that he had a mucocele, which was missed by some other doctors from an outside specialty. And supratemporal would be lacrimal gland. Pulsations are important. No bruit, you'd typically find neurofibromatosis or meningoencephalocele. And CC fistulas or dural AV fistulas may or may not have any sort of bruit. So sensory and motor dysfunction is also very important. That can sort of organize into your head whether it's infiltrative or not. Most common orbital, now this is a very extensive list, don't get overwhelmed, but I think know the most common things. So now preseptal cellulitis, it's anterior to the orbital septum, posterior structures may be inflamed, and there's no extraocular muscle restriction. Typically the conj is not injected, but it may be, but typically it's not. Since the HIV vaccine, you really don't see Haemophilus anymore, but there are more strep forms. In children, they travel very quickly. Orbital cellulitis, typically 90% are from sinusitis. Patients have systemic findings as well, so they'll have fever, proptosis, chemosis, restriction of motility, pain with eye movement. So the clinical exam is so important. It's more important sometimes than imaging. Complications, especially in children, where the diagnosis isn't made and treatment isn't placed. That's a good board question, is cavernous sinus thrombosis. Study that Jerry Harris did found that children typically have one bug, but adults have many. Okay? So here's a patient that we see. Looks like he has some proptosis. He has conjonction. He has restriction in motility. You can see he's trying to elevate here, and here is restricted. So this is clinical diagnosis of orbital cellulitis. Here's a right orbital cellulitis as well. And we see proptosis and exotropia. And you can see let's see right here, subperiosteal abscess. But as long as you can diagnose a subperiosteal abscess on exam and you'll get a clinical photo, you'll be able to make the diagnosis. Necrotizing fasciitis, patients have pain. That's very important. And patients have anesthesia over affected sites as well. So they typically have pain out of proportion to their exam. Okay? Group A strep. So just memorize that. Mucormycosis, Mucor rhizopus, these are very invasive fungal infections. Know that most fungal infections are not non-septate, but these are, okay? So know that it's non-septate branching hyphae. It's a good question for the boards. Typically, you'll see proptosis and orbital apex syndrome because it is invasive again. Patients are usually immunosuppressed. And there's a black discoloration, and that's because the fungal infection, the fungus actually likes to invade the blood vessels, and it causes a thrombosing vasculitis. So that's the reason why it's black, okay? Again, sign out of proportion to findings. And this can be a lethal illness as well as necrotizing fasciitis. So it's important, to know that for your boards. These are questions that could be asked. Inflammation, most common is Graves' disease, and there's also idiopathic orbital inflammatory syndrome. So let's talk a little bit about thyroid and thyroid eye disease. Patients can be euthyroid, hyper or hypo. That's a question that, they'll give you a scenario where the thyroid panel is normal. It doesn't matter, okay? Women are 6 times more likely to have Graves than men. Ages are middle age, 40 to 44, 60 to 64. But 90% are hyperthyroid at some point. Smoking is the only thing that's found to actually worsen the disease process, okay? The most common ophthalmic feature is eyelid retraction. So that's really important. Optic neuropathy, although it's a huge complication of Graves,